Good afternoon and welcome to today's Recovery Summit presented by St. Clair County Community Mental Health with support from the St. Clair County Health Department. Today's presentation is on addiction, trauma, and EMDR. Before we begin, we would like to go over some general reminders. Please use the chat feature for all your questions or comments. Our presenter will be answering questions as time allows. Today's presentation offers one social work CE and one McBAP credit. If you are requesting professional credit, you must remain on the webinar the entire time for credit. There will be a survey following the conclusion of the webinar. Those of you that are requesting social work CEs, a completion of the survey is necessary. And now I'd like to introduce our presenter. Shannon McKeever has worked in the field of clinical social work for 12 years. During her undergraduate work, she received a certificate in addiction studies from Madonna University. She then went to get her master's degree in social work from Michigan State University. She is a fully licensed MSW and a certified advanced alcohol and drug counselor. She is trained in many evidence-based treatments, including eye movement desensitization and reprocessing. Welcome, Shannon.
Thanks so much, Christy. So, hi, everybody. I am going to kind of go over EMDR today, what EMDR is, talk a little bit about trauma, and also about addiction. And then there's also EMDR protocols that can assist with people that experience addictions. So I do apologize for the lighting. I have attempted multiple ways to try to get better lighting, and unfortunately, I am very dark, so I apologize for that. So I'm going to start with just introducing myself a little bit. Christy kind of gave the brief over information. I worked at CMH for many years. When I ended over there, I was working in the substance use primary department. So, and I had really worked with people with with addiction and recovery for most of my career, if not all. So this is just really something that's near and dear to my heart. When I had the opportunity to be able to learn EMDR, I welcomed it, because I think EMDR is an absolutely wonderful training. And when I was doing my research for this prior to this presentation, somebody his name was AJ Popke. He was the founder of one of the protocols for EMDR and addiction. And he stated within his career, he had never met anybody that had an addiction that didn't experience trauma. So that really kind of stuck with me too, as I was creating this, that how significant trauma is with the population of people with both substance use and other types of addictions. So let's start out with what is trauma, right? So I was going through a bunch of different things to find out a definition of trauma. And Bessel van der Kolk, who is one of the leading experts in the field, says it's not the event that happened. Trauma is how you respond to it. So trauma is very subjective to each individual. That's one thing that I've had to learn within working with individuals with trauma, who've experienced trauma, that just because I perceive that something would be a trauma for somebody, it doesn't necessarily mean it was. And on the other side, because I don't feel that it would have been a trauma for me, doesn't mean the person didn't experience it in that way. We have a lot of background, childhood experiences, things that influence our perception and our ability to deal with life events. So that really kind of surrounds that idea of trauma and how trauma is stored in the body and how we respond to traumatic events. Perception of trauma versus the reality of society. As I said, it's not always the same perception. I have had people that I've worked with that have had experienced significant physical, emotional abuse through childhood and identified that that was not a traumatic childhood, but in turn would reference war vets, is that's where a person would experience trauma. And that's not necessarily, that's more of this media perception than what actually trauma can be. So trauma is stored in our brain differently than other information. When we experience an event that makes us feel like we are in danger, which ultimately is a trauma, our stress system opens. It affects our hypothalamus, our pituitary, and our adrenal systems. And so when all of that opens up, our frontal lobe, which is our higher reasoning, doesn't necessarily engage in that. And that's for a reason, right? Because we don't want to have to spend time on assessing the situation, on trying to figure out the best alternatives, and choosing what our best decision would be. Instead, we want to react to the trauma as as we're experiencing it in a way of survival. So that's, I mean, we're designed for that because we want to survive. So when that happens, that system opens up in our brain, and we've taken the information, we take in self-talk, our experience. Well, when the trauma no longer exists, when we no longer feel like we're in danger, that system shuts down, because we can't be in fight or flight all the time. Just, it's not a sustainable state. Excuse me. So with that, what ends up happening is information gets stored in our brain in a location that's not easily accessible. That's where we get into those pieces of, if you've ever felt differently than you thought, like, I know that I'm good enough, but I don't feel like it, or I know that I'm worthy, but I don't feel like I am. That disconnect is much of the time a trauma or a core belief created by a trauma or a previous experience that's stuck in that system that you cannot process through. When somebody experiences a trauma, best thing to do is to talk about it. Most common thing to do is to avoid it. Avoid conversations, avoid being able to discuss what we've experienced, right? So in that avoidance, what it does is it creates and solidifies the storage, and we don't allow us to open up that system and to talk about it, because it's uncomfortable, right? Like, we get, like, when we talk about an accident, our heart will start pounding, our breath will start getting short. And so we don't necessarily want to experience that again right after you had an accident. So what we do is we don't talk about it, or we don't talk about what happened in childhood, because we don't talk about that outside of the family. We don't talk about what happened with whatever individual may have assaulted you, because that is not something that we discuss, because it's your secret with them. So due to that, all of that is being reinforced to be able to really lock in that belief system. So multiple environmental factors, that's that piece of, if your family talks about things, if it's okay to talk about things, if it's a welcoming environment, if you have friends, family, a teacher as a child, somebody that you can feel like you can confide in and be safe to express yourself, safe to be able to explain what happened. But if you never feel safe, you're never going to talk about it. So there's multiple forms of treatment for trauma, but EMDR is going to be our focus today. So just a brief history on EMDR, eye movement desensitization and reprocessing. It was developed and studied and published by Francine Shapiro in the late 80s. In 1990, the EMDR Institute was founded according to their website. The EMDR, the Eye Movement Desensitization Reprocessing and Reprocessing International Association, EMDRIA, was created in 1995, and it states that there's over 13,000 members. You have to pay membership, so not everybody who is trained in EMDR will be on that site, but it is a really great resource to be able to find people who are EMDR trained, EMDR certified, consultants in training, or a consultant. Those are like the levels of EMDR certification. So it's used in multiple countries. So that's the reason why it's an international association. So I was at the EMDR conference. I wasn't able to go this year because you actually had to go. But last year I had the opportunity to go because it was virtual, and there were people from all over the world in like the chats, and it was just amazing to see people from all these different locations coming together with one passion for one form of treatment. It was just absolutely phenomenal. So EMDR is a therapy that assists people with reprocessing trauma using bilateral stimulation. I have pictures of my little tools here that I use. These are my tappers. This is like my go-to. TheraTappers they're just really easy to get out, and I really kind of use these more than anything else. I have a picture of my light bar, which is over next to me over there. Next to the picture of the light bar are the tappers that are associated with that. So these here are, oh, I became lit. So these here have another, like these are attached to the light bar. So it has a right and a left in the hand things, because this will correspond with the light. So as the light goes to the right will vibrate. As the light goes to the left will vibrate. So it uses two different forms of bilateral stimulation in comparison to the TheraTappers uses one form of bilateral stimulation. Bilateral stimulation ultimately is something stimulating one side of your brain by enacting one side of your body, and then again engaging with the other side of the body, the other side of your brain. Your brain kind of does this cross thing. So the right side gives you the left, right hand being vibrated, gives you left side information, which is pretty much your data. When the left side vibrates, right side of your brain goes off, and that's like the creativity. So you get your pictures and your emotions and all of those things. So with EMDR, there's an 8-phase approach. So it is a very, very standardized type approach when we're working with individuals. There is some ability to move around with that, but for the most part, it's pretty cut and dry on what we're supposed to do. You start with like doing your history and giving the information about what EMDR is. Then your preparation, where you kind of, talk about these are the tappers. This is how you use them. This is what it'll feel like. This is what you're going to experience. If you're in distress, you can do a stop signal. You can stop. You can put the tappers down. You can tell me to stop, and we can stop and take a breath. But we're always going to push through. We're always going to go back to it, because then we start talking about some of the analogies. It's like going through a tunnel in a train, and you get out in the middle of the tunnel. There's a light on the other side, but you can't get there because you've stopped. So instead, being able to make it through from one side to the other. And then it gives other resources. Like there's a movie screen analogy where we can pull ourselves out. Our memories are just a whole movie. So we can pull ourselves out of that first person spot, sit down and watch it on a screen. We do not have to experience it first person. Or other things that I'll do is I'll just say, stand by or be with your child self during that. So that way you're able to observe the experience. So those are just some of the things that we talk about in phase 2. Phase 3 is getting set up for the actual reprocessing. So we're going to talk about, and I actually will get into what the definitions of these are. but we're going to talk about the positive cognition. We're going to talk about the target memory. We're going to talk about the negative cognition, what your SUDs are. We're going to talk about all these different things to get set up for body scan. We're going to talk about all of those things. And then in phase 4, we're actually going to reprocess. So we're going to start with the target memory, tell you to take a breath and go with that and allow, which is kind of pressing play in that home movie to move forward and to be able to experience that thought process. The one thing about EMDR is it's not necessarily linear. So you can start with a memory and end up going through 10 memories in one processing session. I had one person explain it to me like they made it a collage. And they were able to see all of the events that were associated with. So it was multiple memories that they were able to process through during that time. The negative cognition is what moves us forward. So that's the route it's going to take. And again, I have a slide on terminology. So when I get to that, I'll be able to explain the terminology of this. Next slide. Awesome. So already explained kind of what bilateral stimulation is. Body scans. We talk about body scans in phase 3, phase 4, and phase 5. And what it is taking from the top of your head down to your feet. Notice any disturbance. Do you feel short of breath? Do you feel your stomach upset? Do you feel your shoulders tight? Do you feel any type of muscles being tight? Had people that their legs have been tight, like a feeling like they need to run. I've had people that have like their head all of a sudden starts pulsing, right? Because there's a book called The Body Keeps a Score, and it really kind of talks about how our bodies hold our trauma. So this is where we're looking at, where is this trauma held to you? Negative cognition. Negative cognition is what do you believe about yourself when you think of this memory? Excuse me. So it could be, I'm a bad person. I'm worthless. I'm unlovable. I'm no good. I can't do anything right. I'm not good enough, right? Like all of those things that we have floating in our heads at times, they're linked to something. You learned it. You're not born thinking you're not good enough. So there's something that brought that to you and made you believe that. And then as life goes on, we solidify that thought process, right? So with that, that's kind of what we end up, that's what we're looking at to process in the EMDR. So the negative cognition is going to drive where the memory goes. So that's why we really have to kind of look at it, because if you're going to do I'm not good enough, you're going to get a whole lot of memories of showing when you weren't good enough. So we want to make sure that, especially at the beginning of processing, because we don't want to necessarily go to the high numbers right off the bat, got to be kind of conscious of what negative cognition we bring into it. Positive cognition. What's the message that you want to change it to? I am good enough. I am capable. It wasn't my fault. I did nothing wrong, right? Because you know that you did nothing wrong to be abused when you were physically assaulted as a child, but you feel that it was all your fault. So being able to kind of separate those things, and the whole goal is to transition from one thought process to the other. Resource development and installation. It's creating resources that we can use within ourselves to be able to help us go through this journey. A set is 24 back and forths of bilateral stimulation. And what we do is we do a set, we pause, we ask, what do you notice? We'll do another set, we pause, we ask, what do you notice? So what we do there is we want a little bit of information to make sure that the processing is still going, but we don't want to, we don't want to enter too far into the frontal lobe. So we don't want like a story. We just want like, hey, where are you at, and making sure that things are going. But that's where sets are used. Subjective units of distress goes back to, what is trauma? It's a subjective perception of an event. So where is that for you? Somebody might feel it at a 5, another person might feel it at a 10. They could experience the exact same thing at the exact same time, and they could be anywhere on that scale. So this is something that we use, and actually primarily use that and body scans to make sure that the processing is happening and that the person is moving along in the resolution. So that's kind of, we talk about the SUDS a lot. What are your SUDS? I have it like in 2 different locations in my office, so I can point to and refer back to it. Target memory, it's that beginning of the home movie. Where does that start? TISIS is a worksheet. When somebody has a distressful situation, we have them, track it. So if somebody's struggling and they leave at a 5, we want to give them a TISIS worksheet to make sure that they understand what their cognition is, what image they're seeing, what cognition, what the trigger was, the emotions. Because when they come back the next week, I need that information so we can really look at that and be able to look at the triggers, the validity, it's supposed to be, of cognition, which is looking at the positive cognition and how true does that feel to you. So if you're at a 10 that I'm a bad person, being a good person is probably going to be at a 1 or 2, right? Because I don't feel like a good person when I think of this memory. I feel like I'm a bad person. But what happens is, as the negative cognition becomes less true, our logical mind takes place and our positive cognition becomes more true. So again, that's the assessment on the transition. Cognitive interweave is another term that we use. And what that is sometimes people will get stuck in a thought process, right? Because for 20 years, you've thought it's your fault. For 40 years, you've thought it's your fault. So being able to say, oh no, I'm good. It's not my fault. I did nothing wrong is not an easy transition. So what we do is we use pretty much Socratic questioning to move from one place to the other. So if you were talking to a friend, would you say the same thing to yourself? If you thought of it in a different way, what would that look like? If you could talk to your younger self, what would you tell them? To help kind of look at this transition. I'm not putting thoughts in, I'm just stimulating other thoughts to be able to help to move from point A to point B. So I'm going to pause for a second. Christy, do we have any questions?
All right, yeah, we do have a few questions. Someone asked, will you be talking about options to attend EMDR training and getting certified in Michigan?
I will give that information. That's not a problem at all. I'll be happy to give out that information. So pretty much if you go on EMDRIA has all trainings on them. And what happens is you get EMDR trained part 1 and 2. Part 1, you can go forth and start it. Part 2, learn some of the other details. But if you go on the EMDRIA, EMDRIA.org, I think it is, website, it will provide trainings. You become trained, and then after you've met with, I want to say it's 75 different individuals, 10 hours of training, 10 hours of individual consultation, and 10 hours of group consultation, then you can become certified. So like there's a transition, and then it moves to consultant in training, and then a consultant, and those are the people that are able to provide supervision and also provide the trainings.
All right, and some of these you may already be addressing later, so just let us know. But the next one are, what are your thoughts on EMDR being done virtually now post-pandemic?
I have a coworker that does it, and she swears by it. I personally don't do it myself, but that's my own issue, not the process of the EMDR. So EMDR is effective. over the internet, doing it virtual. They can tap by taking their fingers back and forth. They can tap on their legs. There's programs that have light bars that go back and forth. Those are all effective. I have my own phobia or paranoia of the internet going down. And so I don't personally do it, but I know many people that do it. It is highly effective.
All right. And can you do EMDR bi-weekly or wait until you can see an individual weekly?
So processing takes, right here, no, that's about the training. Processing takes about 7 days. It's about a week that your body still continues to process. You can do EMDR bi-weekly if needed. I prefer to do it weekly, and especially when I get into my 7, 8, 9s, and 10s. I really kind of want them in with me, and I want to continue it going. Just because the flow of it, and we don't want to sit people out in distress. But if you do take the training, that would be something that you could talk to the trainer, because I'm sure that they have more experience in this. It's what I was taught in my training to do weekly, and I have found that to be effective.
Okay, we have a couple more. Is complex trauma more difficult to treat than specific trauma?
Yes. Somebody who has it just is. So complex trauma starts in childhood. You have a lifetime of situations, multiple situations in which you've experienced. A person that had a single car accident in their life that doesn't have that, everything else has been peachy keen, that is a lot easier to do EMDR on. I have a individual who we just process somatics because they do not have memories of their childhood, but they know something happened, and it comes up and we can tell in the somatics, and once in a while we'll get flashes of information, but that person has a pretty significant complex trauma. So we've worked with each other a lot longer and have a lot more to process because there isn't even information there.
And one more, can you talk to your experience regarding whether EMDR shows more positive outcomes with trauma than trauma-focused CBT?
I am not trained in trauma-focused CBT, so I cannot speak on that. I've only been trained in PE and EMDR. So I really can't speak too much of trauma-focused CBT. All I can say is that I've seen really good results with EMDR and people's transitions from their negative cognition to positive cognition happening in 1 or 2 weeks. So that's really all I can speak on that. So professionals and benefits of EMDR. And if you have any more questions, I'll stop again at some point. Who can provide EMDR therapy? Mental health professionals that have been trained in EMDR. Specific training takes 5 to 7 days, depending on who's providing it. There's also, they have to be able to provide it. So you're looking at people who are consultants. In addition to that, you also will have additional consultation with your consultant afterwards. I want to say it was 10 sessions of group. So you still are able to talk to somebody who has experience in it when you start getting into it, because it's one of those things you don't know what you don't know until you start it. So that's something that and even finding other peers after that point to be able to bounce ideas off of people that have more experience. My coworker, as I said, that does it virtually once in a while, we'll talk about it. What do we do with this? What do we do with that? I also still I'm with another consultant, not the one who trained me, but I do monthly consultation meetings with actually it's my friend's consultant who trained her trainer. I meet with him and four other EMDR therapists, and we bounce ideas off of each other, talk about, hey, I'm stuck with this situation, because no matter how far you go and how much experience you have, there's always another set of eyes that might see something different, just as we would in therapy anyways, right? Like as therapists, we always kind of check in with other people or have supervision to be able to get those ideas. So there's multiple diagnoses. Although it's an evidence-based practice for PTSD, it also works on a ton of other things. So it doesn't necessarily mean just PTSD. And as you notice, substance abuse and addiction is one of those things that also violence and abuse. They do protocols with EMDR. So like this is just treating anxiety, OCD, and mood-related conditions. These are the protocols just for those, right? And I have one that's about twice the size for more specific things, like panic disorder. And so like they have these books with these protocols, because again, EMDR is kind of like a scripted therapy. So this shows your scripts and the information that you need and how to be able to do that once you're trained. This isn't something you have to make sure that you're trained in order to do this. But you can either do trainings on it, or they do have these different books for different protocols on Amazon, or you pretty much can get it anywhere. So areas that are specifically that you really should get significant training in, that isn't something that, like I could go into anxiety, phobias, panic attacks, kind of, that's a good transition from just being trained, although I'm at the level of certified now, but like dissociative disorders, dissociative identity disorder, those take specialized training to work with individuals with that, because when you start getting into alters and you start getting into people dissociating, you need to know how to get them back. You need to be able to make sure that you're talking to the core person, and what happens if they transition to another personality and another identity, like what does that look like? So that's a specialized training that you really need to focus on. But EMDRIA has a ton of trainings. So, and they're really cool. You get them for like 2 months or a month and do it as you can. So that's actually how I took Detour, which is what we're going to talk about in a little bit. So EMDR and substance use. These are, again, when you're talking about protocols, these are 3 of the protocols for EMDR and substance use. So when somebody has a concern with substance related or even maladaptive behaviors, right? Like, so if you're talking about a gambling addiction, if you're talking about a food addiction, if you're talking about, right, spending addictions, right? These also can you can kind of look at these things with these processes, but these ones specifically are meant for addiction protocols. So again, these are scripted. They're they're approaches that you would have a specific set of information in which you use to be able to do it. I'll show you the Detour when that I think is the next slide. So CraveX, it's craving extinguishing approach developed by Michael Hayes. This approach hinges on the reprocessing of an addiction memory, the memory network that develops the specific to the client, involving the cravings and compulsions to use or act, right? Like, so again, this will work on process addictions or also substance use, but kind of looking at the cravings and what happens and your compulsion to use the substance in which your primary substance of use. So it results in the cravings being extinguished. That's the focus, is about the cravings themselves. So being able to, the theory on this is if you don't crave, then you won't use, right? Now, any of these protocols can transition to not just their protocol, but possibly transition to a typical EMDR session at any time. Because if you get into a space where you're looking at a memory coming up, that's that specific memory, you can transition into an EMDR processing. These protocols are kind of separate from that. And they're the same. I mean, you use bilateral stimulation, you use your script to set up, right, all of those things happen. And also, there's other stages that they don't use in those. Whereas, going back to, here's my little EMDR cheat sheet that talks about all of the stages that we do use for EMDR, for like a standard EMDR session. So FSAP, Feeling State Addiction Protocol, which is developed by Robert Miller. This protocol involves identifying parts of the addiction experience that feel good to the client, but are ultimately part of the addiction they wish to cease. So you're really kind of focusing again, and you'll notice that these have different focuses that make the whole of addiction, if that makes sense. And then and I'm not as familiar with that one, Kravix. I've had some information, I've done some studying on and learned about it. Detour, which is going to be on the next slide, I'm trained in. That's the one that I chose to be trained in. And I'll explain why in a minute on that. These other two are just ones that I've briefly touched on. So I don't necessarily have as much information, but EMDR has a lot of resources for that. Or you can look, the internet has a lot of, and again, looking at .orgs, .edus, .gov information, not like Wikipedia, but has more information on these other protocols. We can't be well versed or completely versed in every protocol because that would be so overwhelming and my brain would burst, honestly. So just kind of looking at, because again, this is half the size of my other book. And so I can't, there's no way that I could be able to do that. But it's interesting on all the different types of protocols because they've worked with and found what is best, or ability to have the ability to be able to help transition people from where they are to where they want to be. So this PEIA, it's interventions in addiction, and the concept was developed by Marcus and Hornsfeld, and it's the framework for understanding EMDR and addiction treatment. The authors introduced the idea of two lenses of EMDR addiction treatment strategies. So a trauma-focused EMDR and an addiction-focused EMDR. So that kind of like separates those two. Now I'm going to kind of talk a little bit on Detour, but do we have any questions right now?
Sorry, we did have a question. What coping skills are needed for someone to be able to handle any stress from EMDR and working through their traumatic memories?
Okay, so things that we do to be able to assist somebody, we do that in the preparation stage. So in standard EMDR protocol, what we do is we create what's called a safe or calm space. A lot of this is internal resourcing. So creating a space in your mind that you can go, that you feel calm, that you feel peace, right? So some people will be a cabin in the woods. Some people are walking by a stream. I've had somebody that was just floating in space before. Just some place that you can almost be in a meditative state. Take that moment to escape your second of distress and be able to de-escalate. And honestly, for me, Another thing that I do is a lot of the times I give them like distress tolerance skills because I'm very lucky to have been also trained in DBT at one point. So that's kind of what I also do, but that's not necessarily EMDR protocol. But I think distress tolerance skills and emotion regulation skills are like absolutely interchangeable for like they're universal. Everybody should learn it. I truly believe that. So that's another resource that I give them outside of EMDR. I also give them like the crisis line, mobile crisis unit. I give the information for that. I have cards and magnets to be able to hand them, to be able to have somebody to call if it's 2 o'clock in the morning and need to talk to somebody. We create a list of who are your supports, who to call. We also do what's called a container. The container is, again, something that you create in your mind, something that's big enough to hold all of your stuff, that's secure, that you can be able to just kind of put it on a shelf or put it away for a little bit. It's not that we're not going to come back to it. And that's something that we have, I have to stress. It's not an avoidance technique where I don't ever want you to look at this again. It's in this moment when I'm driving down the road and I heard a car backfire, I cannot sit in the moment of, whatever had happened then. So I need to be able to set that aside because I still need to drive home, right? So that's where the container piece goes. So a place in your mind that you can put the distress, you can put the stuff. The memory is always going to be there, but you don't have to sit with all of the, you don't have to sit at a 10. If you can get yourself down to a 3, then it's more manageable to be able to get home. And then looking at your skills, what to do. There's other internal resourcing also, like finding somebody that you know, and Detour also uses this, finding something that you know, finding an experience that you had that was a positive state, or somebody you know that represents strength or courage, and then we kind of try to create that, and we'll create triggers, trigger spots on your body to be able to help kind of associate those things together. So those are all things that we can do. We also teach grounding techniques for people that dissociate.
Someone was wondering if you could give the name of the book that you were holding.
Eye movement desensitization and reprocessing therapy, scripted protocols and summary sheets. So if you just go into, like, I got mine from Amazon. If you just go into Amazon and you Google EMDR protocols or look up EMDR protocols, there's probably like 20 of these different kinds of things. And there is one that has addictions in it. So I just have some at home and some here, which I probably should bring the ones home here because I use them here. But yeah.
Do you have any resources on emotional regulation skills?
Emotion regulation skills, again, my go-to is DBT, and there are reproducible DBT skills out on the internet. I actually have them tabbed in my computer, but I can't get out of this because it'll totally screw everything up. But it's, there's websites because they have created those, and actually therapy notes, not therapy notes, what is it called? Therapist helper, I think maybe. What is the name of that site that helps with worksheets? Sorry, I'm digressing here, but
They put in the chat that it's therapist aid.
Thank you. Yes, that's what it is. I had to Google it. But Therapist Aid also has stuff on emotion regulation. They have a lot of DBT skills there. And so that's something. And I always start with people about cognitive distortions too. That's another thing that I truly feel is part of the package, because if we can identify our cognitive distortions, if we can identify our faulty thinking ways, and be able to really look at how our catastrophizing, how our fortune telling, our mind reading, our these different things, the all or nothing thinking, how that affects us, those cognitive distortions. If we can identify that, when we start to become emotionally dysregulated, we can also check our thoughts, because that can create a lot of anxiety. So if we can check our thoughts and come back and be like, okay, what's my proof that everybody hates me? Well, I've talked to about 5 people today and none of them told me to go fly a kite, so therefore they didn't hate me, right? Like, so, and it's allowed to kind of pull yourself back some. So that's just another piece of it. Christy, any others?
One more thing. It says that this person works in a detox center. I'm assuming EMDR would not be appropriate for our short-term contact with our clients. Is that correct?
EMDR is something that I would definitely link people with. Unfortunately, the insurance company doesn't allow people to stay long enough. Ideally, in my little world, it would be great to have like a 2-month recovery and then EMDR just be part of that, but it's just not a possibility. So unfortunately, in certain settings, it would be very effective. If that setting could ever exist, I would highly encourage being able to start processing some of those core memories. The other side of it is in the way that our processes are, most likely not, but being able to get somebody to a trained EMDR therapist that is able to work with both substance use, that understands substance use and also understands trauma, and being able to work with them would be the second best thing. So detour. This is the training I took. And the reason why I chose detour is because this is the other substance use or addictive behavior protocols require the individual, or highly encourage the individual, to not be active in use. Detour it's not like we want them to use, it's highly discouraged. But if somebody is active in use, it's just saying, please don't be high when you come, right? Like, it's just asking, because that can inhibit processing. But if you need to start drinking at 11 o'clock in the morning, let's do a 9 a.m., right? Like, let's figure out a way to be able to help you process this. And also, if I'm not going to tell you I can't give you this treatment because you're active in use. So that's the reason why I chose this specific protocol. So it is focuses on triggers and urges. So like we talked about with Cravex, where it was the cravings that we looked at, this is actually looking at what triggers you and where is your urge to use. A.J. Popke is the one who created this or came up with this. He passed away during COVID. So we definitely lost a great mind in that. He actually was friends with Francine Shapiro. So he knew about EMDR from the very get, right? Before EMDR was actually EMDR. So he went and he actually went back to school, because I want to say he was like an engineer or something. I can't remember what he was, but he went back to school after EMDR was created and got his degree so he could do this. I digress. But the protocol focuses on desensitizing the triggers to reduce the cravings. It includes establishing a positive treatment goal. So again, the other piece of this is we don't focus on the negative, I want to stop. We focus on, where do you want to be, right? So moving forward, what does that look like? What do you want? How do you want your life to look? How can you get there? Instead of, how dare you be using, how, right? Like, because although you're not saying that, people can experience that feeling, unfortunately, and we don't intend it in any way, shape, or form. By no means would I ever say that to somebody and mean that. It's just when we're telling somebody that, okay, what are you going to do to stop? Or what are skills are you going to use to be able to not use? Like, that's telling them, but if you do, what emotion is related to that? But instead, looking at with this, what do you want? What do you want it to look like? How do you want these goals to move towards? What does life look like without use? What does life look like if you no longer use food as an emotional support? What things do you need, right? Like, whatever the maladaptive behavior is, that's what they're called in the protocol. Whatever those behaviors are, be it use or other types of addictions, like, these are ways to be able to kind of change that mindset even from the get-go. So, you start out with Detour with starting rapport. Rapport obviously is always the most important. Get your history, your diagnosis, assessment, support resources, your internal resource state, right? Like, so when is a time that you felt the way you want to feel, right? Even if it was just a moment in time that you felt that confidence that you wanted to feel, or you felt what it was like to experience happiness, or you felt when is that moment? We're going to take that picture and we're going to make that grow, and we're going to focus on that picture, and we're going to make that and take that with the positive goal, and we're going to connect those, because with this positive goal and taking the positive state in which you've experienced before and marrying those in your mind and being able to really kind of create that resource for you, because you remember that experience and you want this experience and how that would look, and how it kind of gives you that motivation to keep stepping forward. So that's where you're talking about the internal states, right? Like, getting those things together in somebody's mind to be able to resource that. So like I talked about resourcing people with EMDR, or resourcing safe spaces. This is resourcing an internal states and positive goals. Instead of using SUDs, subjective units of distress, you use levels of urge. So where is your urge? Because again, you're looking at triggers and urges. So on a scale of 0 to 10, where is your urge to use right now? Where is this urge for you? Because you're kind of looking at those pieces so you can assist the person to, because that's what you're looking to decrease. As you increase these positive states, as you increase these positive goals, this level of urge, because that part of your life is what prevents you from this part of your life. And so, or can get in the way of. So instead of targeting trauma, it targets the triggers and urges. It targets what triggers you to want to use, triggers you to want to engage in that behavior. And so instead of looking at, there's just this specific memory, we're going to look at the sound of the car crash. We're going to look at the smell of somebody's cologne, right? We're going to look at those types of things, and where that traumatic event is attached in the world, to be able to take out that part of it. And if the trigger is no longer there, the urges decrease. So we are almost at time. I think this is, yep, that's the last one. Look at that. So Christy, is there anything else that was asked?
I think we got it all. The only thing was someone had asked if you could put the name of that book in the chat for their reference. And they wondered who the book was by.
Marilyn Lubber is the editor. Here, hold on, I'm gonna stop sharing. So we're gonna have a whole lot of nothing there. And I am going to my keyboard. I lean on my keyboard all the time, and then I turn off my camera, unfortunately. Let's And so if I go in here really quick. All right. Oh, come on. It's making sure, I know that we're like running way out of time and we have to end. X, J, Y. G, E. Sorry, typing is not my skill. I did not go to typing school by any means. Yeah. I don't know if you can take it really quick, but that's the Amazon page that you can get it on. And then again, if you just look at that in general, it's going to give you all associated ones. There's a ton of these different books. Probably not supposed to be promoting Amazon, but sorry, that's where I got it. All right, and thank you guys all for being here. I truly appreciate it, and I appreciate your interest in EMDR and substance use and addictions, because there are way too few of us that do this, and it is such a phenomenal it's such a phenomenal treatment for people. I have seen people's lives transformed with EMDR, and it is like my go-to. I absolutely, absolutely love it. I don't see the information for the book. That's because it's up in the chat, but here it is again, because I copied and pasted it, so I have it again.
All right. Thank you so much, Shannon. That was a lot of great information. Just as a reminder, the Recovery Summit is going on all month with different topics and speakers planned each weekday. Tomorrow's presentation will be at 10 a.m. presented by Dr. Alex Elswick on Addiction 101. To see information and register for additional sessions, please visit sccmh.org under the Events tab and Recovery Summit. Individuals requesting professional credits, you will receive your certificate of accumulated credits by October 30th via email. As a reminder, please submit complete the short survey at the conclusion of the webinar. Thank you again, Shannon. Your time and information is appreciated. And thank you all who attended today. Have a great day.